So good evening guys. If I'm visible and audible, give me a thumbs up. Actually, I just can't see the videos, your messages. Just trying to figure out. Somehow that I just can't see the messages here. Am I audible? I can see 6 of you watching it, but I can't access the messages. And I'm getting a thumbs up also over there. Now I've seen more people joining in. I mean, I can see everyone joined in, but I'm not able to see the messages that you're typing. And I don't know why. Yeah, good evening. So I did see if Dr. FMG, Dr. Sushma, Dr. Sneha. Okay. Okay, all of you. Am I visible and audible now? So Dr. Sneha is what I can see. Dr. FMG, Dr. Sushma. Yes, guys. Yeah. So good evening, Dr. Priya, Dr. FMG. Now I'm getting all your messages. So let me just start. So I can just go through your messages and see them also. Let me start with the session finally. So I can see all of that. Right. So I'm able to see all your messages now. Yeah, Dr. Sneha, Dr. Priya. Yeah, all set. Fine. So good to see everyone who have joined in also. Just give me 2 seconds. So we'll wait for some more people to join in, and then we'll start with the session today, that is revision of MCQs of anesthesia. Basically, we are going to take care of the anesthesia drugs. This is what going to take place, anesthesia drugs, and we will discuss MCQs based on that, and based on MCQs then we will discuss the concepts. Okay, So just to introduce myself to you, my name is Dr. Vinish Srivastava, presently head of the department, Associate Director of Anesthesia and Critical Care. I am working with the Fortis Lafam Hospital in New Delhi. Skipping out other things, let me just go forward. Okay, so now I'm associated with Unacademy. So people who haven't followed me up, please do follow me up so that you know when my next classes are going to be held. The point is, since we are on YouTube, a lot of people don't know about the app. So the people who haven't downloaded, people who are still preparing for FMGE entrance exams, NEET PG, and in fact now let me add, NEET apart from FMGE and NEET PG, people who are already in professional 1 year, first prof, for them also Unacademy has all the courses that can help you out with your exams. Okay, so download the app for all of you who are seeing this, and the ones which get recorded who see it later on as well. You need to download the app. You need to enter a code just to enter inside. So any code you can enter that you have with you. Today what we are taking a YouTube session. Normally what is there is a plus course which is subscription based. A special class is what is supposed to be free. So when you download the app, you get these three options immediately after you open the app. So the plus is which is subscription based. This is basically for people who are preparing long term. All right. Why am I telling you this? If I don't tell you, then who will tell you? How will you people come to know as to what to take and what not to take? People who are already prepared, who just want to test their knowledge, who feel that they are well prepared, can join the special classes which are totally free, take part in most of the MCQ discussions which have been open over here, okay, and that can take care of all the things, okay. So, yes guys, am I audible? All of a sudden I lost your messages. Initially I was getting them, now I've lost your messages. Yeah, Dr. Sushma said yes, but yeah, okay. So as I was continuing, so for all the classes you just need to have a code to log in. You can use Vinish Live or any other code that you have. So going forward for that, remember the special classes also that we have. Yeah, Dr. Shalu, I got a yes from you also. Thank you. So for the special classes that we have, guys, the same thing as a plus course, you have the interactive classes. There are polls which are going to be held. Okay. Dr. FMG says सब smooth चल रहा है. Good. Okay. Thank you. And you get all the features of never missing a class, lecture notes, and available anywhere, anytime. As I said, the plus course is basically who are preparing for long term, who have just started the preparations. Is good for them. They can take a subscription for a long course, for the long preparation, where you get live and recorded classes both. You get to compete in tests and quizzes. You have an access to the question bank, and you can study on the device of your choice. Okay, Iconic is a good thing, which is a combination of Unacademy and Prep Ladder both. It's best of both the worlds, and I feel this is again basically for people going for a long-term preparation or people who have just started to prepare. Okay, so that you've got all the literature and material in your hand to prepare for it. Okay, congratulations to all the toppers who have done well for FMG December 2021. This is the NEET PG free calendar test for the month of March. Remember, now these are the things which are going to be held. So tomorrow again you have a previous year's test series which is mixed bag 5. Okay, that's at 4 p.m. Please remember that. Okay guys. Then we have a previous year question bank where dedicated 3 years, past 3 years papers are covered, and you have the solution also. We'll understand all the concepts well. Okay, so this is again to introduce to you people. A new thing that has been launched is Unacademy Lite. Alright, so this is the NEET PG's test series basically, which includes overall 450 more than practice tests. Alright guys, so this is an Unacademy Lite. As I was discussing before also, for MBBS Professional 1, again for them as well we have courses where you can just join in. So right from your first year of MBBS, we'll take courses, and that prepares you not only for your entrance exams but even taking care of the MBBS part. Okay. So these are the doubt clarification series, which is a part of the Plus platform, alright, where you have interaction with all the educators. Okay, so again the doubt clarification series is a new thing, right? These are the two things now which are going to be running as of now: NEET PG 2022 high yield batch, theory batch, theory revision, and FMGE 2022 high yield revision batch and MCQ batch. Okay, so please be aware for people who want to take the subscription for this. Again, this is the last thing. Additional 20% is there for subscriptions. Alright, so people who are just thinking about taking a subscription can go ahead right now. So going forward and starting, just telling people who haven't followed me up, please do follow me up so that you come to know when the next sessions are being held. Going forward, straight away with our question number 1. Okay, that's my Telegram ID. Any questions or doubts you can ask me at my Telegram ID. I'll try to solve them to the best of my ability. Okay, so which one of the following is used for the treatment of anyways, what I'm going to say before I just decide, discuss with you. Let me tell you what I'm going to discuss. This session right now is a 1 hour session. In this 1 hour, what we are planning is basically taking help of previous year's questions. What I have done is added 1 or 2 more questions, or maybe change some options. So in that case, what we have done is we have previous year's questions plus few more questions. As I said, 1 or 2 more questions. Based on that, we are going to revise our anesthesia drugs. Okay, so anesthesia drugs, basically what I am trying to cover today is IV drugs. We are discussing few of inhalationals, and we'll try to cover the important muscle relaxants. So all the drugs that take care of general anesthesia, we'll try to cover them one by one. Okay, so which of the following is used for treatment of malignant hyperthermia? So Dibucaine, Doxycycline, Dantrolene, Droperidol. So there are 4 options given to you: A, B, C, and D. Is it A, Dibucaine, B, Doxycycline, C, Dantrolene, or D, Droperidol? Anyone? So I'm waiting for your answers. Dr. Suran says C. Dr. Yash says Dantrolene. Anyone else? Yeah, just type in your answer. So I'm seeing it, and I'm writing here as well. So I have the mobile in my hand. Dr. Sushma says C. Easy question, huh? No one made any mistakes. Absolutely correct. Okay. So the people who marked the answers correctly, absolutely correct. It is Dantrolene. All right. Dantrolene. Dr. Sneha also says C. All right. So Dantrolene. That's the correct answer. When you speak of malignant hyperthermia, remember when we are discussing malignant hyperthermia, so how did this question come up here? Remember, malignant hyperthermia is a topic which is common both to general anesthesia as well as local anesthesia, both of them, right? Then I get Dr. Satvik also saying C. Yes, Dr. Satvik, nice. Okay, so I was talking about malignant hyperthermia. It's an important topic for general as well as local anesthesia, for both of them. And this question again was asked in 2021 NEET PG, where they asked, and FMG, sorry. So where they asked you, the way that malignant hyperthermia is a disorder of which channels. So first of all, malignant hyperthermia is an important concept that you people need to know. It's uncommon, not very common in Indians. It's a genetic disorder. Okay. So what is this? Is basically a genetic disorder. So malignant hyperthermia, guys, remember, it's a genetic disorder of sarcoplasmic reticulum. All right. The sarcoplasmic reticulum has something called as the ryanodine receptor gene. Okay. Sorry. Okay. It's a ryanodine receptor gene abnormality. Dr. Yash has said calcium channel. Correct. This ryanodine receptor basically is a calcium release channel. So therefore, what happens? It's a genetic disorder of sarcoplasmic reticulum. So what am I supposed to do, like in anesthesia? Why is it related to anesthesia? The point is, this patient will be walking, talking like a normal patient, but as soon as this patient comes inside the OT, so remember, this will happen inside the OT. It's not going to happen outside on the road. So what happens is, Dr. Abhishek says hang. Dr. Julie says ryanodine receptor. Am I visible, audible, guys? Ki hang ho gaya? Should I refresh? Dr. Abhishek has said hang. Let me check. Okay, let me check once. It is fine now, says Dr. Sushma. Okay. Dr. Yash says working fine. थोड़ा सा I think I need to refresh. So just give me a second. So there we go. All right. Right. So as I was saying, this is a genetic disorder of sarcoplasmic reticulum. All right. Let me just start from here. I will just finish off in short in 2 minutes. Okay. So it's a genetic disorder of the sarcoplasmic reticulum having a ryanodine receptor gene abnormality, which is a calcium release channel. So now what happens is the patient who is having this genetic disorder of sarcoplasmic reticulum gets exposed to anesthesia drugs. Which drugs? So more often that you see is halothane, again MCQ question, and not just halothane, any volatile anesthetic agent. So be it halothane, isoflurane, desflurane, sevoflurane, all right, or even enflurane, either of these drugs, all of them are going to cause malignant hyperthermia, but maximum is seen with halothane. Apart from that, muscle relaxant succinylcholine and local anesthesia drug lignocaine. So any of these drugs given to the patient suddenly causes some problem in the ryanodine receptor. It causes huge amount of calcium release in the patient. This huge amount of calcium release suddenly changes the electrolyte abnormality. Remember, all the calcium is going to get released from the muscles. So basically what is going to happen is you are having electrolyte abnormality in the patient. Correct? Increased calcium release is going to lead to increased metabolism, and therefore muscles also get involved. All your signs and symptoms come out because of these reasons: electrolyte abnormality, increased metabolism, and the involvement of muscles. Now the point is, what is the treatment of this condition? So you will find a lot of books even having mentioned propofol. No, propofol is not the treatment of this condition. The treatment of the condition is somehow or the other to stop this release of calcium. The drug that stops the release of calcium from here is called dantrolene. So dantrolene stops that release of calcium. Hence dantrolene is used for the treatment of malignant hyperthermia. Thumbs up everyone, is this point clear? So when this happens inside the OT, the treatment of malignant hyperthermia is dantrolene, dantrolene sodium. Okay, thumbs up everyone, is that okay? Anyone with one thumbs up also, I'll go forward. Yes. Yes guys. Okay, so Dr. Sushma gave a thumbs up. Okay, so going forward, now imagine, because this is a genetic disorder, the same patient comes again for a surgery the next time. So remember, I can't give him local anesthesia with lignocaine. I can't give him general anesthesia with halothane and succinylcholine. So therefore, when this patient is going to come for the surgery next time around, then for this patient, my drug of choice, okay, so when he comes for surgery, my drug of choice for this patient, if I have to give general anesthesia, is going to be Propofol. And if I am going to give this patient local anesthesia, my drug of choice is going to be Procaine. And that's why this question becomes important. If you can see, it's a drug of choice for general anesthesia, Propofol. Drug of choice for local is Procaine. It's common to both GA and LA. Even the causes are common both to GA and LA. So this is a common question between both general anesthesia and local anesthesia. Okay, hopefully these points are clear. Three important questions, all of them, in fact, whatever we have mentioned here on screen, all are questions. In fact, this was the question this time around. This is a disorder of which channel? Calcium release channel. So all these are MCQ questions based on this part. Okay, so going forward, Dr. Julie says, what about non-depolarizing? Non-depolarizing you can give, it's basically to do with succinylcholine. Okay, so non-depolarizing is not a problem, but more importantly what happens is these patients are very high risk patients. You have to be very careful when you're dealing with them. This is a genetic abnormality. Most of the times you always take a high risk consent from these patients and proceed with the surgery. Okay, so going forward. Okay, so kindly identify: A, Propofol, image based; B, ketamine; C, thiopentone; D, methotrexate. So I'm looking at the messages also. All right, so waiting for your answers and then we'll discuss it out. So I got one answer. Other people? Just one answer, Dr. Julie. Dr. Julie has given two options. No, I am giving only one option, Dr. Julie. Dr. Life says one answer. The only three people giving me an answer. Yeah, there's so many of you over here. Fast. Fast, fast. Dr. Rishi has given an answer. Yes. Fast, 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 fast. Let me have the answer so that we can discuss and move forward. Yeah. As I say, all in my classes, I want the discussion also to take place. I'm not someone who's going to discuss one MCQ and then, you know, or maybe 10 MCQs. Dr. Kirti says A. So my point is to discuss an MCQ, and based on the MCQ, you need to have some discussion which actually makes sense as to why the MCQ has been set up. Dr. Pooja says A. Dr. Mahantesh Patil says A. How come A here? I think only Dr. Julie had that query there. Dr. Nana NEET PG says A. सबसे important point is question में क्या है? I don't know whether you can see it clearly or not. Maybe that may be an issue. Okay. See, the point is what is written over here. You're seeing a diagram. So let me give you again. It is given 500 milligram. What you are seeing here is a written powder for injection. If you're not, it's not visible, so let me put it this way. It's powder for injection. Alright, so I think most of you have marked it Propofol. That's exactly why I put it up in this way. Right. So now Dr. Pooja, Dr. Sushma, Dr. Life and Dr. Julie, Dr. Yash. Okay, so it is given 500 mg powder for injection. Alright, so the powder for injection, guys, remember the drug is what? Thiopentone. Important point. It's thiopentone. The correct answer is C, thiopentone. Alright, I know. So this is one question which has never come in the exam in this manner, but I just took a diagram, alright, and from a diagram of thiopentone, all I did was I covered thiopentone, which was written over here. So what was written is thiopentone 500 milligram powder for injection. So all I did was I hid that thiopentone written. So you have two things in front of you. One is 500 milligram, other thing is powder. So many times I do expect you not to remember the dose of thiopentone 500 milligram. But what is expected of you to remember is thiopentone is what comes as a powder. It comes in a powder form. Important question. Like if anyone will say white color drug, so all of you will straight away say yes, the white color drug is Propofol. So remember, it's not just Propofol which is white in color, because it's a white emulsion. It's not just Propofol. Remember, even etomidate is supposed to be a white emulsion. Like the one preparation of etomidate does come as a white emulsion. Okay, so etomidate, alright, etomidate is again looking as a white emulsion. So now Dr. Pooja says available as yellow colored powder. Dr. Rishi says okay. Alright, so important point. So now we have discussed that Propofol is white in color. This is done. Ketamine normally comes as a clear liquid. Normally, okay, it comes as a clear liquid. That is what is available in India. That's the way that we also available to us. When you speak of thiopentone, remember thiopentone contains thio, and thio is sulfur. So basically thiopentone contains sulfur. If you go back to 12th standard chemistry, sulfur was hygroscopic in nature. It can absorb water, okay, yellow in color, and that's exactly because thiopentone contains sulfur. It comes as a yellow powder. Important question. So the powder drug normally that comes from anesthesia, if someone will ask you, that is going to be thiopentone. Okay, antibiotics come in powder form, but anesthetic drug which is normally used, anesthetic drug which is used in powder form normally is thiopentone. This comes in as a yellow powder. Okay, so this is an important point. Yellow powder is because it contains sulfur. Alright, so because it is in powder form, remember, and it's an IV injection, remember it's for injection. So you always have to mix it with something so that it can be given IV. So what do you mix it with? Always remember, you mix it with normal saline. Books have said that you can even mix it with 5% dextrose or with distilled water. Okay, you can mix it with this also. Ideally with normal saline. Remember, here RL normally is contraindicated. We do not mix the thiopentone with RL. It tends to precipitate. Which brings me to one more point. Okay, it tends to precipitate. Yes, Dr. Srivastava. Okay, so with RL it tends to precipitate, and not just with RL, because thiopentone, it's a, Dr. Nana says, can you just explain? Explain what, Dr. Nana? Question. Because it is a powder form, a drug will always tend to precipitate anytime, and that's the most important. Why yellow and why powder? Because it contains sulfur. Sulfur is in yellow in color, same thing. Sulfur comes as a powder, this will also come as a powder. Hygroscopic in nature. Okay, if you keep it outside, it will absorb water. Okay, So just remember it comes as a yellow powder. You don't need to remember anything more than that. Okay, that's not important at your level. Just remember it comes as yellow powder. Nothing more is needed. Okay. So that's one of the ways to remember thiopentone. Yellow powder, it contains thio. Alright, and because it's a powder form, guys, it can always precipitate, and the point is whenever it precipitates, or whenever thiopentone precipitates, you need to throw the vial away, because if you don't throw the precipitate, you are going to inject the same thing inside the vein, and which is going to lead to trouble inside the patient. Okay, so that is why a precipitate is never to be injected inside the patient. Alright, and that's another reason that you must have seen when thiopentone has a side effect, that in case it forms a precipitate, it's gone IV, it can cause thrombosis. Venous thrombosis is known side effect that can take place with, I mean not every time, but with thiopentone. And you must have also heard that in case instead of an IV and a venous line, in case thiopentone goes inside an artery, alright, it can cause vasospasm, and that vasospasm can lead to gangrene. All you people would be knowing this. Gangrene is one of the things that can happen with thiopentone if it goes intra-arterial. This question has been asked many times. Alright, so in the vein there can be thrombosis, in the artery there can be vasospasm leading to gangrene. Thumbs up everyone, point clear? Yes, Dr. Pooja, that is gangrene. Okay, clear? So that was slightly tricky, I think. This looked tricky. I did not seem tricky to me, but somehow they turned out to be a tricky question. So that's why you don't realize many a times. Okay. So I thought it's a very simple question because I just set up powder. I mean, this question has not been asked in the way that I've asked it over here on YouTube today. But normally this question has always been asked in the form of which of the following is in powder form. So like they give you options the same way. Thio. Here I just put an image and I, hit the part of thiopentone. So that was the only difference, the way that I've set up this question over here. Okay. Which brings me to a point that it was a good question finally. Okay. It was a good question. Now, next point. Atracurium is known to cause what? Thyroid dysfunction, hypertension, histamine release, all of the above. A, B, C, D. Only 3 answers till now. Other people, fast. Answer fast. Only 30 seconds. That's why, on the app, what happens? We set a timer. I mean, for the people who are on the Unacademy app, they would be knowing. We set up a timer and we give 30 seconds or 40 seconds depending on each. So I get to see everyone's responses then and there itself. Here it becomes slightly slow, but still it's okay. At least we get we can make some sense of a discussion. So I find equal divisions between people writing histamine release and people writing all of the above. Okay, C and D. Remember guys, the answer here correct is only histamine release. Okay, histamine release. C is the correct answer. Yes, Dr. Yash. Yes, Dr. Yash, absolutely correct, as Dr. Yash pointed out. So let me bring this point to you. This question has been asked in exam. So when I'm discussing, so atracurium is what? It's a non-depolarizing muscle relaxant. Okay. So what I'm discussing with you are muscle relaxants. Remember, muscle relaxants are classified into 2 types. Okay. One is the depolarizing muscle relaxant. Other is the non-depolarizing muscle relaxant. Now, depolarizing, there's only one drug available with us right now. You people know, that is succinylcholine. Non-depolarizing, you classify them into 2 types. So we classify them basically based on structure as aminosteroids and benzyl isoquinolinum compounds. Okay, there are some others also, but let's not go into details of those 2 things. Basically, this is what is asked in exam. So whether you have pancuronium, okay, whether you have vecuronium, whether you have rocuronium, okay, so pancuronium, vecuronium, rocuronium, or rapacuronium. Okay, so all these are aminosteroids. Benzyl isoquinolinum compounds, you will get something like doxycurium, you get that DTC. Alright, then you get this was the first drug, D-tubocurarine, and then you get drugs like atracurium, mivacurium. Okay, atracurium, mivacurium. Alright, so these are benzyl isoquinolinum compounds. Remember, pancuronium is the drug that increases the heart rate, that increases the blood pressure. Okay, this drug. In others, there's one drug called as galamine. This drug is not used nowadays. This was another drug that used to increase heart rate and increase blood pressure. Apart from that, guys, rocuronium is one drug that increases only the heart rate. Rest, all other drugs are not going to cause so many changes in terms of increase. Vecuronium, remember, is the most cardio-stable. Because it is the most cardio-stable, guys, that's exactly why it is the most common use. So all of you would be knowing vecuronium. Right, Dr. Rishi? As Dr. Rishi says. Dr. Pooja says Hoffman's. I'm coming to atracurium in a while. Just give me a second. Now I'm discussing the cardiovascular properties. So you had a confusion between hypertension and histamine. So I'm discussing those properties related to heart. Correct, Dr. Rishi? So when you speak of DTC, this is the drug that decreases the blood pressure. This was used for arterial surgery in the past. Now it's not used anymore. Okay. And atracurium. Atracurium is one of the best drugs. The reason being best drugs we say is because it has that Hoffman's elimination. Okay, as all of you have mentioned to me here itself, it has Hoffman's elimination. Okay, so Hoffman's, all amino steroids, says Dr. Srivastava, Dr. Namrata, is that they are cardiostable? They are most of them, and that's how you say that amino steroids. If you will see amino steroids, they normally not just cardiostable. See, it's only vecuronium and pipecuronium that you're going to say as cardiostable. Huh? You will see pancuronium and rocuronium are going to make changes from amino steroids. Benzyl isoquinolinum compounds, more of them are causing problems with histamine release. Okay, amino steroids are the ones that increase the heart rate and BP, sort of, except vecuronium, which is cardiostable, and pipecuronium, which we don't need to know about. Vecuronium is important for exam purposes. In benzyl isoquinolinum, you'll find DTC causing the maximum histamine release. In fact, you'll find even atracurium and mivacurium causing histamine release, and that's a problem. So remember, what happens with atracurium is that atracurium is one of the best drugs that we know. Remember it as 2H. Atracurium causes Hoffman's elimination, which is a good property. So 70% undergoes Hoffman's elimination, which is spontaneous degradation. And another point is that it also causes histamine release, which is not a good point. And histamine release can cause bronchospasm. So remember, the histamine release in this patient can cause bronchospasm, pruritus, and this is the reason for slight decrease in blood pressure that is seen with atracurium. Okay. So with atracurium, you never find increase in blood pressure. This thyroid dysfunction was just given as time pass. Normally, none of the non-depolarizing are going to affect the thyroid function so much. It is basically thiopentone, which is not supposed to be used for thyroid patients. So it is just an extra option. So here the correct answer is only histamine release. Had there been hypotension also given, that could have been the answer. But here the correct answer is histamine release. In fact, this is what causes hypotension also. And because it causes so much histamine release, atracurium, which can cause, that's exactly why they made cis atracurium. Now cis atracurium becomes more potent. Histamine release is not there. In fact, that even ester hydrolysis, atracurium, you'll find 70% undergoes Hoffman's and the remaining 30% undergoes ester hydrolysis. It forms a metabolite called duodenosine, and this is known, accumulation is known to cause seizure. In cis atracurium, that metabolite is not there. So therefore, the problems, histamine release and that formation of metabolite, are not seen with cis atra. So remember, cis atra becomes a better drug than atracurium wherever possible. Okay, so wherever you found that atracurium is the drug of choice, as you people have mentioned, in liver patients and renal patients, reason is because of Hoffman's elimination. You will find better drug is cis atracurium, because it is not only more potent than atracurium, it is derived from atracurium, it retains the same Hoffman's elimination, but it has no histamine release which is seen, and at the same time that metabolite production which causes seizure is not seen. Thumbs up, guys, is that okay? So that is atracurium, important point. For atracurium, remember 2H, Hoffman, and histamine release. Everyone okay? So let's take the next question. Are all of you okay? Thumbs up. Is that fine? Hopefully. So Dr. Sushma says thumbs up. All right. So the most preferred drug, and Dr. Jayan, Dr. Julie, Breezy, Jayan, Dr. Yash, Dr. Rishi. Okay. So most preferred drug for burn dressing in the ward. So there are 4 options given to you. Let's take the next question. Good. I got a thumbs up from all of you now. Thank you. What happens with the thumbs up? I understand that you've understood. YouTube, it takes time, and we've got a habit now since we are taking online for the last 2 years. So we've got habituated to that thumbs up. Even in the class when we take special classes or plus courses. So what we do is we ask for a thumbs up, so we know that you people have understood. So most preferred drug for burn dressing in the ward: A. Ketamine, B. Methoxytol, C. Etomidate, D. Propofol. Again, this question never has been asked in this manner that we have set it up, okay, right now. The one answer I am getting right now from Dr. Sushma. Dr. Yash. Others, they're still taking some time to decide. So Dr. Tarun and Dr. Nana NEET PG says A. Dr. Taruni says A. So all of you have said A over here. Absolutely correct. The correct answer is ketamine. So 2 points were, as in the question itself, the drug is supposed to be used for a burn dressing. So what is this? Basically a short procedure. Alright. More than short procedure, it is supposed to be done in the ward. Remember, out of OT anesthesia. You are not giving it inside the OT. If you give inside the OT, you will use drugs, all the anesthesia drugs that you use, whether it is thiopentone, whether you're giving propofol, you give etomidate, all these drugs are induction agents. At one point of time, they're going to decrease the respiratory rate in the patient. Okay, so patient is going to go stop breathing. You're supposed to maybe intubate the patient, or you will be giving a bag mask ventilation to the patient. Here, you're giving it out of OT in the ward. You don't know whether you'll be able to intubate. Of course, we can intubate, but you don't have your anesthesia machine. You don't know whether you can continue the anesthesia over there. So therefore, in the ward, I'll rather prefer to have a drug which kind of maintains the respiration. So all you will find with ketamine is a drug that causes the least respiratory depression amongst all of them. It causes the least respiratory depression. All right. It also maintains the airway reflex. So these are the 2 reasons that you'll find ketamine is a drug of choice in the respiratory system also. No. Apart from that, there's third point as well. Okay. And that is, it's a very good bronchodilator. Okay. So therefore, it's a drug of choice in a full stomach patient, drug of choice in respiratory system. All right. It causes least respiratory depression. It kind of maintains the respiration. Apart from that, an important point again is that most of these drugs, if you remember, we have discussed this point here in YouTube also before, that most painful injections from the induction drugs, etomidate is as painful as propofol, which is more painful than methoxytol, which is more painful than thiopentone. Okay. Alright, so we have etomidate, almost same as propofol. Then you have methoxytol. Alright, it's not midazolam. And then you have thiopentone. However, ketamine is out of this. Ketamine, remember guys, is one drug which is different. You will find all these drugs, thiopentone, methoxytol, propofol, etomidate, they all work at GABA receptors. Okay, ketamine what works at NMDA receptors. All these are induction agents, but you see ketamine is different to all of them. So all these drugs basically are painful in nature. They cause pain on injection. Ketamine on the other hand is an analgesic drug. It works at NMDA receptor. So therefore what it is doing is has an analgesic property on its own. So basically you are giving an anesthesia drug which has analgesic properties. It is a drug which is kind of maintaining respiration. Alright, so when it works on the brain, the type of anesthesia produced by it, as Dr. Namrata says, is dissociative anesthesia. Absolutely correct. It dissociates two parts of the brain, so it produces dissociative anesthesia, and therefore this drug becomes the best drug to be used for burn dressing in the ward. All right. So it's not methoxytol, it's not etomidate, it's not propofol. Okay, it is going to be ketamine, which is the drug of choice here. It's the most preferred drug for burn dressing in the ward out of OT anesthesia. So right, doctor following my dreams also says NMDA receptors. Okay, and any questions over here? I'll go forward to the next one. Let's take the next question. So here we discuss the most preferred drug for burn dressing in the ward. Okay, thumbs up everyone, all okay? So we'll take the next question. All right. Okay, says Dr. Yash. Nice. Okay. Which one of the following is the safest to use in a patient of bronchial asthma? I got a thumbs up from all of you. Right, Dr. Tarun. Okay. Dr. Yash, Dr. Julie, Dr. Sushma, Dr. Namrata, Dr. Nana, Dr. Taruni, Dr. Tarun. Thank you for letting me know. So Dr. Julie, Dr. Sushma have given answers. I'm waiting for others. Dr. Nana says an answer. Dr. Abhishek, Dr. Yash, Dr. Tarun, everyone, all of you, correct, absolutely correct. I deliberately mentioned this none of the above. Okay, I mentioned none of the above because what I did was when I was discussing the previous question, I had mentioned with you ketamine. Okay, so I already said bronchodilator, so I had to change the option here. Otherwise, it did not make any sense to ask the question, right? So I changed because I discussed bronchodilator. I was thinking of discussing it later, but I discussed it there itself. Okay, so when you speak of atracurium, I just told you it causes histamine release. All right, so you're not going to use it in it can cause bronchospasm. Similarly, thiopentone also causes histamine release. Desflurane, on the other hand, inhalational agent, is the most pungent. In fact, it is said to be the most pungent. Most pungent means it causes the maximum bronchial irritation. This is 2019 NEET PG question. Drug which causes maximum bronchial irritation. Okay, so hi Dr. Abhinav. Okay, so good evening to all of you and all the new people also have joined it, and I know all of you have stuck on. We are taking good night, good evening. Dr. Abhinav का hello sir बोला, फिर Dr. Abhinav is saying good night. Dr. Abhinav is off to sleep, okay, or off to a party. But today is Wednesday. Still people have Wednesday parties also, Dr. Abhinav. Maybe you are there. Chalo, good. Okay, imagine all of us are studying and Dr. Abhinav is maybe out to party or out to sleep now. Okay, so good for Dr. Abhinav. All of us will study anyways. Is that okay? All of you, sorry for that. I just got diverted a little bit. Dr. Abhinav said good night, so I also said good night to him. Okay, so as I was discussing with you, desflurane, most pungent, it causes maximum bronchial irritation. So therefore you have a patient of bronchial asthma. Would you like to use a drug which is causing histamine release? No. Again histamine release? No. Desflurane, maximum bronchial irritation? No. What is the drug of choice then here? From all the options given, ketamine. Reason, it is one of the best bronchodilators. It is one of the best bronchodilators, right? So this is the correct answer here. Bronchodilator, ketamine, that is the best drug to be used in a patient of bronchial asthma. All right. Let's go forward. Okay, let's take another question. So, which one of the following is a coronary vasodilator? So, Dr. Tarun को भी शायद नींद आ गई है? नहीं. Dr. Zul says D. Okay, so let's take this question then. Which one of the following is a coronary vasodilator? We take A. Thank you, Dr. Sushma. Without asking for a thumbs up, Dr. Sushma, I think, gave a thumbs up. Thank you. Okay, we took halothane, isoflurane, desflurane, and sevoflurane. So 4 options are given to you. Which one of the following is a coronary vasodilator? So as you can see, we are trying to revise all the drugs, okay, slowly and steadily. We have taken care of IV drugs, we took muscle relaxants in between, we discussed local and anesthesia again together. Oh, Dr. Abhinav says DMLT student हमें भी स्टडी करनी है. अरे डॉक्टर अभिनव, मोस्ट वेलकम, कोई दिक्कत नहीं, आराम से पढ़ो डॉक्टर अभिनव. होपफुली जो मैं बोल रहा हूँ कुछ तो समझ में आएगा आपको. थैंक यू फॉर ज्वाइनिंग एट दिस सेशन डॉक्टर अभिनव. अरे हम डॉक्टर ही बोल देते, चलेगा, ठीक है. यू आर वर्किंग इन द मेडिकल प्रोफेशन, यू विल बी वर्किंग द सेम थिंग. आप भी ऐसे काम करोगे तो ऑल गुड. सो प्लीज आंसर, सुन लो आप, अंडरस्टैंड दैट एंड इज इंपॉर्टेंट थिंग्स. सो नाइस टू सी. अनाट फिजियो यार यहाँ पे नहीं होगा अभी, ये तो एनेस्थीसिया पूरा. लेट मी सी द अदर ऑप्शंस. डॉक्टर रुपेश सेज बी, डॉक्टर सुषमा सेज डी, डॉक्टर राजर्षि, नाइस नेम, Dr. Rajarshi. I have not heard that name before. Good. A. Dr. Yash says B. Dr. Abhishek Ranjan says B. Dr. Abhinav Tiwari says please sir. I can't take anat physio. I will teach anesthesia. Dr. Abhinav. Dr. Taruni says B. My friend Tyson says A. इस पे मेरे कुछ बोलने का मन कर रहा है पर मैं नहीं बोल रहा. Following my dream says A. Dr. Namrata says C. अरे what such a big confusion from all of you. This was again an easy question. सब कंफ्यूज हो गए. ए बी सी डी. अपार्ट फ्रॉम डी एवरीवन हैज आंसर्ड ए बी एंड सी. लेट अस डिस्कस दिस इंपॉर्टेंट पॉइंट नाउ. ओके, विच इज अ कोरोनरी वेजोडाइलेटर फ्रॉम हियर? ओके, द करेक्ट आंसर इज कोरोनरी वेजोडाइलेटर बी, आइसोफ्लोरेन. सो मोस्ट ऑफ यू आर करेक्ट. अरे डॉक्टर अभिनव, आई नो अमेथी गौरीगंज, मैं वहाँ पे आया हूँ, संजय गांधी हॉस्पिटल में वर्क डिड ऑल्सो, वहाँ पे मैं वी हैव डन लॉट ऑफ वर्क देयर ऑल्सो. ठीक है, सो डोंट वरी, आप पढ़ाई करो, स्टडी अभी. एनीवेज, लेट्स डिस्कस द क्वेश्चन हियर. कोरोनरी वेजोडाइलेटर. सो हैलोथेन, डेस्फ्लोरेन, सिवोफ्लोरेन. सो यू आर गेटिंग 3 ऑप्शंस विच आर रॉन्ग. द करेक्ट वन इज आइसोफ्लोरेन. रिमेंबर, व्हेन वी स्पीक ऑफ आइसोफ्लोरेन, ऑलराइट, when we speak of isoflurane, guys, remember isoflurane in inhalational agents is the best drug for the cardiac system. It's the best drug for the cardiac system, right? Reason why? Because isoflurane maintains the cardiac output. When you will speak of halothane or enflurane, अरे माई फ्रेंड टाइसन, यहाँ पे गलत हो गया, चलता है. अंडरस्टैंड द कंसेप्ट बिहाइंड इट एंड व्हाट आई एम कमिंग टू. आई डिस्कस द पॉइंट व्हाई दिस क्वेश्चन इज इंपॉर्टेंट. लेट मी डिस्कस फर्स्ट नाउ. This is a small word called coronary vasodilator, but based on this is an important question that comes in the exam, and that exam I think, and that question I've asked in my YouTube sessions, guys, and you people know it. If I just change it slightly and I write it, which one of the following causes coronary steal phenomena, and then you'll be right. Did you realize, all of you? The people who made it wrong, if I just cut this point here, which one of the following causes coronary steal phenomena, all of you are going to write the correct answer. Do you see? That's how questions come in the exam, and that's how they get twisted. Okay, all right. So this is the way the question comes in the exam. So coronary vasodilator jo hai, this is the property because of which you are getting the coronary steal phenomena in the patient. Now coming back to isoflurane. Isoflurane is a drug that maintains cardiac output. All right. So what the reason for maintaining cardiac output is that it maintains the baroreceptor reflex. ठीक है. Because of this reason, it maintains cardiac output. Hence, drug of choice in any cardiac patient is isoflurane. That's a very good thing. The point is, now cardiac patients would also include patients of ischemic heart disease or coronary artery disease. So let's take an example of these ischemic heart disease and coronary artery disease patients. Another property of isoflurane is that it is a coronary vasodilator. That's a property. So it's supposed to be a good property. It's dilating all the coronaries. So this is supposed to be a good property, right? It's dilating all the coronaries. But when it comes to ischemic heart disease and coronary artery disease patients, guys, what happens is, imagine if this is a patient here, okay, and these are the coronaries of the patient, and here is a plaque, okay. Okay, here is a plaque. ये आ गया plaque. This is a plaque over here on the coronary. So what happens is, this area which you see, this becomes the ischemic area, this becomes the normal area. So all of us know there are collaterals that get developed and blood supply gets increased. So all this ischemic area, into this ischemic area, what is happening? The blood kind of gets diverted from the normal area. The normal area still remains very, very thin. It is a good blood supply. So even a small blood supply of these coronaries is okay. You don't need to have it dilated. However, the ischemic area has got more blood supply now. If you can see, this is what is happening to the ischemic area. Our ischemic area has got more blood supply. Do you realize this now? Guys, all okay? This is what is seen. Abhinav Tiwari, please let us just discuss. यहाँ पे discussion चल रहा है, so I'm just asking questions to them. So kindly, we'll discuss that once my session is over. कोई issue नहीं है, okay? Now the point is, guys, I was saying this is the ischemic area, this is the normal area, okay? Now you can see the blood supply to the ischemic area is more and the blood supply to the normal area is less. This is what has happened in a patient of ischemic heart disease or a coronary artery disease, okay? This is what is there. You have a plaque, all right, and the plaque has decreased. This is the ischemic area then. So what does the body do? It develops the collaterals in such a way that your blood is started flowing to the ischemic area, okay? And these coronaries are already dilated to the maximum. Now I give the patient a drug like isoflurane, or in fact you must have studied in pharmac also, hydralazine or dipyridamole. This is a common question, huh? Dipyridamole. So these drugs are coronary vasodilators. These drugs are coronary vasodilator. So now what happens is, once you give a coronary vasodilators, they are going to dilate all the coronaries. So now let's take an example here. Now this is the same coronary is getting dilated, okay? So you are giving, I'm talking of isoflurane, hydralazine and dipyridamole, especially of these three drugs being coronary vasodilators. What happens in them? So now once you give these coronary vasodilators to these patients, all the coronary vessels are getting dilated. Can you see? So everything is getting dilated. This is also got dilated. This is also got dilated. All right. However, on the ischemic side, this was already dilated maximum. Somehow the other I am unable to write it over there. Okay. So this ischemic area was already dilated, okay? This ischemic area was already dilated, okay? So therefore, once you start using coronary vasodilators like isoflurane, hydralazine and dipyridamole, do you realize the capacity to dilate these normal vessels is much more than the capacity to dilate ischemic vessels which are already dilated? So therefore what happens, the blood starts to flow sort of more into the normal area, less into the ischemic area. So the normal area gets more blood supply than the ischemic area, and this is what is called as coronary steal, that the normal area is stealing the blood from the ischemic area. Thumbs up everyone, point clear? This is why this property is important. Coronary vasodilator is what is leading to the phenomena which is called as coronary steal phenomena. Dr. Abhishek says dipyridamole can't be given. No, in case if they are given, that's exactly why you don't give, Dr. Abhishek Pandey. Okay, that's the reason. Isoflurane, hydralazine and dipyridamole. That's exactly why you have this confusion. You people must have seen many times in exam questions also, they have written some patient, you find drug of choice in a cardiac patient, isoflurane. Suddenly in some patient you'll find drug of choice, sevoflurane. Why do you find sevoflurane? The reason is because in some patients, especially with ischemic heart disease, coronary artery disease, myocardial ischemia, there is a reservation in the use of isoflurane because of this coronary steal phenomena. However, said and so, people still say the best drug to be used in a cardiac system is still isoflurane, okay? But question mark hota hai, two books, two people, two examiners might still think differently. They might think no, rather than using isoflurane which can still cause a little bit of coronary steal phenomena, might as well use sevoflurane. All right, so this is why you find those discrepancies, differences or the controversies in medicine, okay? So these are the reasons you could get those discrepancies. Thumbs up, clear everyone? That is what is called coronary steal phenomena. Had I set up the question just as coronary steal, all of you would have given it correctly. I just kept it as a property. Which of the following is a coronary vasodilator? And the correct answer for that is isoflurane. That is the reason why it causes coronary steal phenomena. ठीक है, hopefully you've understood this point everyone. I think so. Okay, so let's take another question. Okay, so which one of the following produces a maximum greenhouse effect? Ether, enflurane, halothane, nitrous oxide. Remember, this is a very important question. If you don't answer this question, someone with flag will come to your house. You know na? People are carrying flags right now. They go to everyone's house. They'll come to your house then. So we are scared that these people will come inside our OT. No. I'm just saying. Okay. Alright, so most of you, all of you in fact I'd say, all of you have marked the answer, have marked it correctly. Okay, so without wasting any more time, and it is nitrous oxide, absolutely correct. The drug which produces the maximum greenhouse effect out of the ones is nitrous oxide. Okay, so nitrous oxide, remember, is a drug which was discovered in 1773. Today is 2022. It is still being used today. Reason, as a carrier of inhalationals. Okay, that's why it is still being used today. But the problem with nitrous oxide is that nitrous oxide is one of the drugs that is decreasing the ozone layer. Because it is decreasing the ozone layer, what it is doing, it is causing environmental pollution. Okay, because it is causing environmental pollution, it is causing greenhouse effect, hence it is called as a greenhouse gas. Okay, it causes greenhouse effect. Therefore people are saying don't use nitrous oxide. Okay, you already spoiled the environment. All right, you're already decreasing the ozone layer, it is causing environmental pollution. Okay, greenhouse effect is going to be seen, so people with flags will come to your house. So then people say don't use nitrous oxide. So what to use then? Dr. Rajarshi says given with oxygen. Correct. All right, so that's the reason it is given. It is a carrier of inhalationals. Let me go forward then. Next question then. So based on that, based on the same thing, so which one of the following can now replace nitrous as a carrier agent for volatile anesthetic agents? There are 4 options given to you. Doctor following my dream says given with. Correct, it's a carrier ना, वही तो बोल रहा हूँ. Correct. Dr. Rajarshi, Dr. following my dreams. So most of you, other people, answers fast. I'm seeing. Okay, so I think most of you have given me the correct answer, and the answer to that is xenon. My friend Tyson. Nice name. So xenon is the correct answer. Dr. Abhishek also gives the answer. Correct, xenon. So the same reason is over here, what we were discussing before, alright, regarding nitrous oxide. Alright, so it is decreasing the ozone layer, causing environmental pollution. Alright, it's causing greenhouse effect. That's exactly, you don't want to use nitrous anymore, so people are doing research on xenon, so that xenon can replace nitrous as a carrier of the inhalational agents. Problem, xenon is expensive. X for xenon and X for expensive. It is expensive to buy. There's no anesthesia machine available. It can cause some bronchospasm a little bit. However, said and so, xenon is still said to be the most ideal anesthetic agent. Alright, so this is a drug that can replace nitrous oxide as carrier, and xenon is also supposed to be the most, it's inert gas. Okay, it's supposed to be the most ideal anesthetic agent. Okay, everyone clear? So let's take one more. Which of the following is seen with propofol? So we will take this as a last question today. Tomorrow again at 9 o'clock I'll try to take instruments. Tomorrow again I'll take at YouTube. I'm going to take instruments. Some people had requested me for that. So we'll take anesthesia instruments tomorrow. Whatever we can discuss. List is endless. But in 1 hour, whatever we can. Okay, so next question, guys. Which of the following is seen with propofol? A. Vomiting. B. Hypertension. C. Apnea. D. Active metabolite. Yes, all of you. So I'm getting answers now. I'm able to see. Okay. All right. All right. All right. Absolutely correct. Oh, absolutely correct. Okay. Remember, for all the people who have marked the answer A, it's not like your second professional exam, second prof, side effect of metoclopramide, nausea, vomiting. Side effect of pantoprazole, nausea, vomiting. I mean, that's how we were in college, right? Am I right, all of us? We were all like this. I don't know whether you were there or not. But if someone asked me side effect of ranitidine in the Viva and you don't remember anything, answer is nausea, vomiting. Okay. The only side effect of every drug that I remembered in my second professional exam was nausea, vomiting, and diarrhea. Okay, for every drug, these were the three things: NVD. So when I went to Gynac and someone said in Gynac, okay, let's do NVD, I said, what? Nausea, vomiting, diarrhea. That's the problem. Okay, so because this was the thing on my side, by the time I was in second professional, this was in my mouth: nausea, vomiting, diarrhea, nausea, vomiting, diarrhea. So when you went to gynae, they said NVD karte hain. I said, what is NVD? Nausea, vomiting, diarrhea. Okay, do we do that? No, no, no. Sorry, that was a PJ. Let's go back. So what I was saying is, all of us who have marked the answer A over here, vomiting, remember, propofol is not a drug, is not the drug that causes vomiting actually. Propofol has a very important property, and remember guys that it is an anti-emetic drug. Anti-emetic, in less doses it can actually treat vomiting. It is one of the treatments, is that treatment of post-operative nausea, vomiting. Dr. Namrata, absolutely correct, but let me discuss that later. Just give me a second, okay? So point is, normally propofol, first point is it is anti-emetic, okay? So therefore this question is out. Propofol is a drug that decreases everything. So whether in the cardiac system, it's going to decrease the BP, heart rate, cardiac output. Respiratory system, it decreases everything, which is the correct answer, apnea. All right, CNS also decreases everything. So therefore hypertension is again not the thing. It causes profound hypotension. Okay, decreases the BP. So in the last two options between C and D, when you see of active metabolite, normally when propofol undergoes metabolism, it does not produce active metabolite, it produces an inactive metabolite. That is another reason why it is preferred to be used for daycare surgery, kidney patients, liver patients. 2 points. Propofol's elimination or metabolism is two ways. The 70% of propofol undergoes metabolism where it takes place inside the liver, but 30% metabolism of propofol takes place inside the lung, which is one good property for the metabolism part. Second point is, when the metabolism takes place, it forms inactive metabolite. So do you see, it's reducing the load on the liver of a patient whose liver is damaged, and that's exactly why propofol is said to be the drug of choice to the patient having a liver disorder, renal disorder. You use it there. Okay, induction agent. It's the most common drug which you can use everywhere, apart from someone who's having shock. If a patient is in shock, someone's BP is low, you cannot be using propofol because it is further going to decrease that blood pressure of that patient. Okay, now it produces inactive metabolite. Dr. Namrata said it produces a metabolite. So Dr. Namrata, the metabolite that you're speaking about, not about metabolite, let me speak up in this manner, that when you start the infusion of propofol, she was speaking about propofol infusion syndrome. This normally happens when you start an infusion of propofol, okay, which is going on for a long time, maybe for 1 or 2 days continuously inside the patient, especially pediatric patient who's admitted in PICU. Okay, so you get high doses of propofol going inside the patient, and that cannot be handled by the small liver of the pediatric patient. okay, which increases the load on the liver. It leads to the failure of the free fatty acid metabolism, leads to accumulation of the lactate, leading to metabolic acidosis, which is seen. Okay, so this is what is seen in propofol infusion syndrome. So metabolic acidosis, you get to see cardiomyopathy, all right, you get to see skeletal myopathy, all those things are seen in the patient. So basically it's a failure of free fatty acid metabolism leading to accumulation of lactate in the patient. Okay, lactate, and that is called what is called as propofol infusion syndrome. Hence people say try to avoid using it in pediatric patients and in neonates. You will see there are hardly any contraindications to propofol. The contraindication would have been contraindicated in a patient of shock. Okay, do not use propofol in a patient of shock, in a patient of hypovolemia. Apart from that, the only contraindication that you can think of where you will not use propofol is a patient who is a neonate, where it's not supposed to be used. Pediatric is again question mark, people are using nowadays, but neonates are not to be used, and even in pregnancy the efficacy is not yet established. Apart from that, guys, propofol is used everywhere. It is the most common drug used, okay, everywhere. Okay guys, so thank you for joining me at this session. Any questions or doubts, ask me. I'll try to solve them to the best of my ability. Okay, thank you all for joining me at this session. Tomorrow again I have a thing at 9. We'll take another session at 9 o'clock tomorrow. Okay, so any questions or doubts you can ask me right now. I'll try to solve them to the best of my ability. Thank you, Dr. Sushma. Thank you, my friend Tyson. नाम थोड़ा सा अलग लगा यार, my friend Tyson, that's why I said that. Okay, Dr. Zul, thank you. Dr. Devanya, thank you. Senthil Kumar, Dr. Senthil. Dr. Nana, thank you. Dr. Tharuni, thank you. Previously, isn't desflurane cardio stable? Yes, Dr. Namrata, desflurane all no. Dr. Namrata, see, when you come to desflurane is the one which can actually increase the BP and heart rate initially. So you have to be very careful. In fact, desflurane is supposed to be the drug of choice in a patient of shock. Okay, Dr. Namrata. Okay, desflurane ideally is used in. Oh, Dr. Tyson, those are big words. Okay, those are big words. Dr. Arun, thank you. Dr. Tharuni, Dr. Nana, all of you, thank you so much. Okay, so Dr. Namrata, hopefully your doubt is clear. All right. So all the best, guys. Do well. Tomorrow again I'll take 9 o'clock. Tomorrow what I'm planning to take is anesthesia instruments. Okay. Thank you, Dr. Tarun. So I'll take anesthesia instruments and we'll discuss MCQs based on that and then see. Okay. Thank you all of you. Okay. So take care. All the best. Do well and catch up with all of you tomorrow again. YouTube. Okay. 1 hour. Tomorrow again I'll take 1 hour. Good night. All the best. Have your dinner. Thanks, Dr. Rachan Khan. Thank you. Thank you, everyone. Thank you, Dr. Abhishek. Thank you. Dr. Abhishek Ranjan, thank you. Good night, Dr. Chankhan. Good night, everyone. Good night, guys. Good night. Still seeing your messages.